Welcome to Chalkwalks. Hi, I thought it would be worth focusing on managing emesis or vomition, particularly chronic vomition. And in this case, we have an 11-year-old female spayed Shiba Inu with 10 days of vomiting. Okay, so this is debilitating the animal, fairly severe, and obviously a diagnosis is the first goal that you have, but you need to help the animal in the meantime. So in this case, ultrasound radiographs suspected a pancreatic mass, not a good thing, and some reason they tried to aspirate it, I'm not sure why, but didn't find neoplasia. That's a pretty risky and also not particularly diagnostic procedure when you suspect a large mass. You can get lucky. So the laboratory's results showed an increased ALP, increased corticosteroid-induced ALP, although there wasn't a history in this case of corticosteroid administration, and increased cholesterol, suggesting possible liver disease or liver involvement. It eventually went to surgery, where it had a partial pancreatectomy, which did detect adenocarcinoma, and had secondary pancreatitis. This is a very tricky surgery. So we have a clear cause. We have an animal that's had, to whatever extent it can be, had the problem reduced, if not removed, and we need to manage vomiting. And so let's look at the drugs that were actually applied in this case. We can talk about the pros and cons. Well, the first one is meropetant, and meropetant is an NK1 antagonist, and neurokinin receptors are often bound by substance P. Substance P is an emetogen, meaning it causes emesis, and so the blockade of neurokinin receptors has an effect to block substance P's effect on the emetic center, which is where everything is organized. The emetic reflex is organized. The chemoreceptor trigger zone. So for chemotherapeutic or toxin problems, this would also block that. And also vagal afferents, probably the most significant, afferents, the most significant input to the emetic center here because of pain and the surgical procedure. So this is what we call because of this, it's a broad spectrum antiemetic. And is now being used widely in a lot of different circumstances. It also has been shown to have some analgesic effects, and this has been shown by reducing requirements for inhalant anesthesia. So we've got a lot of things in this case that would lead to this drug being a useful one to consider. Now the other one that was applied, and these were not all used at the same time but in sequence, was metoclopramide. And metoclopramide is a dopamine 1 and dopamine 2 antagonist, where the dopamine 2 antagonism can lead to the central reduction, so central blockade of dopamine receptors, D1, which is associated with primarily the chemoreceptor trigger zone, and therefore is better for circulating toxins. And the other thing so it has that central effect, it also has a peripheral effect on the pyloric sphincter. So the pyloric sphincter, which leads to its tendency to allow ingesta to move on, and therefore it's called a prokinetic. So when an animal vomits, it needs to close that sphincter and lead to the pressure in the stomach that pushes it out, pushes the ingesta out of the esophagus. In this case, that is more likely, the gastric emptying time is more likely to be more rapid and therefore less vomiting. So it has two effects, peripheral and central and peripheral. And then we have the drug that has been used more and more, dilazotran. Dilazotran is a serotonin 3 antagonist. And it basically, by its effect, is to decrease the vagal activity. So its primary effect is to reduce the afferent input into the emetic center. And in this case, that's clearly a good thing. So these clinicians had applied many of the drugs that one would try, and these are not all used in sequence, but they were different strategies to get at the same effect, to reduce tendency for vomiting. And clearly in this case, as opposed to many short-term, say, viral conditions or whatever, where vomiting can be very brief, dogs vomit all the time. So chronic vomiting can be quite debilitating, and you know the cause, and you don't have an obstruction. So this is clearly a valuable thing to do. So what about the use of sucralfate and famotidine? And I'm going to label these with blue because I think this is a situation where you have, yes, the animal may have stress leading to increased acidity, but we really don't have any evidence that the vomiting is due to increased gastric hyperacidity. So the two drugs used here are sucralfate, which basically is activated by acid, so it's requiring an acid environment, and it works obviously best to treat an already existing ulcer because it sort of binds to that ulcer in an acid environment. And the second one is the H2 antagonist, famotidine. Now these two drugs, when given, need to be staggered because, as we mentioned, the sucralfate requires an acid environment, and so if you've just given famotidine and it's at its maximal effect, obviously the acid secretion is reduced at that point, and so you can have a more alkaline environment. So you usually stagger these. Famotidine can be given once to twice a day, and sucralfate usually every 3 to 4 times a day. So you try to stagger them. In addition, I want to mention that sucralfate can have the effect of binding to other drugs that you might want to give orally. Usually with an animal that's vomiting, you don't want to give oral drugs if you can avoid it because you can't be sure they'll stay down. So that's the other concern here. I don't have any evidence. There's no evidence of hematochezia, meaning blood in the vomitus, which suggesting there to be an ulcer. So I guess I personally would have chosen not to include sucralfate for this animal using famotidine or an acid pump inhibitor like omeprazole, and trying to manage any concern over hyperacidity that way.